everyone, welcome. This is the Northwest Geriatrics Workforce Enhancement Center Geriatric Healthcare Lecture Series. My name is Barbara Cochran. I'm the Associate Director for the NWGWEC, and I would just like to remind you, if you do not have handouts for this presentation, please contact your site coordinators. The presentation has slightly updated slides, so if you would like the updated slides, please get in touch with your site coordinator who knows how to contact me or Heather Wickline-Sanchez, and we can get you the updated slides. Also, a reminder that there is continuing education credit for this presentation. If you would like to get CE contact hours, your site coordinator will have information about how to register and log in to get those contact hours. If you are just interested in seeing the presentation again, or someone else you know is interested, they will be presentations are posted within about 48 hours on our nwgwec.org website, and you will be able to access both the handout and the lecture recording. Today, I'm very happy to introduce a colleague. Her name is Joie Whitney. She has 30 plus, pardon?
I was just waving.
Oh, she has 30 plus years of experience, includes practice, teaching, and research. Her program of research is focused on clinical studies of chronic pressure ulcers or pressure injuries, as I'm learning now is the correct term, and acute surgical wounds and strategies to support healing and or prevent complications. She teaches in the CWCN Wound Management Education Program, and she's faculty liaison to that program from the UW School of Nursing. She's a professor in our Department of Biobehavioral Nursing and Health Informatics, and she is actually the Associate Dean of our Office of Nursing Research. I guess it's Associate Dean for Research. So please welcome Joie. She's going to talk today about current concepts in pressure injury prevention and care. Welcome.
Thank you. Thanks for the nice introduction. And welcome to everybody here in the room, a couple people here, and all of you out in the greater regional area. So Barb mentioned this is exactly what we're going to talk about today, our current concepts and maybe some of the newer things that have happened in the field of pressure injury. Now, it was referred to as pressure ulcers, and now the new terminology is pressure injury. And talked with Barb. I guess we will hold questions to the end, if that works for everybody. She said that's what is commonly done. So we'll go ahead and get started. So the objectives, which I think you've probably seen, we are going to talk a little bit about staging pressure injuries because there have been some recent changes in that, starting with a revision in 2016. Then I'd also like to talk about some strategies designed to reduce pressure injury. And then over selected treatments and preventive measures, talk about evidence-based measures that you can think about employing in practice. And then if you have other questions on things I don't cover, you can bring them up in the discussion section. So here are some questions or ideas that are out there in the universe that pressure ulcers develop because of poor care. Pressure ulcers are preventable. They result from pressure. Specialty equipment prevents pressure injury, and massaging reddened tissue can prevent an ulcer from developing. So those are questions, sort of true or false. And as we go through this presentation, by the time we get through the end of it, you should be able to have a pretty good idea of how you would answer those questions. There's, of course, other ones out there, too. Another one that I might have put in there is that pressure ulcers are not associated with pain. So here's an outline. I'm going to talk about classification, pathways of injury, assessing risk, selective preventive measures, and selected treatments. Really, the field of wound care, wound healing is huge, and I was asked to focus on one particular type of chronic wound, but those of you out there know that are working in clinical settings, there are many types of chronic wounds, but our main emphasis here will be on pressure. So classification, what's new in this area? So originally it was called bed sores, then decubitus ulcers because they were noted in people that were lying in lying positions. Then switched over to pressure ulcer. And most recently in the last couple years, this has been changed over through the work of the National Pressure Ulcer Advisory Panel and also the European Pressure Ulcer Advisory Panel on working on the terminology, trying to get it to better reflect what's really happening in these kinds of ulcers or injuries. So to be clear, pressure injuries are distinct from the three other common types of chronic wounds. Those are listed on the slide. So these are pictures of common chronic wounds. These are venous ulcers. See if I can get our little pointer to work here. They typically present with these kind of features. So we see hemosiderosis here, this dark staining where blood has leaked under the skin. They often have fibrinous slough. That's not just unique to venous ulcers. And they have this thing, presentation of lipodermatosclerosis. So you get this kind of woody appearance to the tissue around them. Those are features that distinguish them from pressure ulcers. They're also located typically in other locations than we usually see pressure ulcers, like the gator region of the leg. So listed there are some of the features of venous ulcers. They do have irregular borders. They are highly exudative. They do have pain associated with them, and they often have this really ruddy kind of complexion with them. And really the mainstay of treatment in these ulcers is compression therapy. So another common chronic wound is the neuropathic ulcer. This is a very typical location that we see this clinically on the plantar surface of the foot or on any of the areas of the foot near the toe region or the metatarsal regions. We typically see with these, more so than one does with a pressure ulcer, this kind of calloused area here. And that is pretty classic and something that's handled during treatment of this type of ulcer. Arterial wounds, typically no pulses, pain with elevation. They feel better. Patients like to sleep sitting in chairs. They like their legs to be dependent. There's an absence of things associated with circulation, like good nails, healthy nails, and good hair growth on the limb. So you also see this shiny skin and cool temperature. And a true kind of punched out appearance is often typical, like we see here. It almost looks like it's a very large punch biopsy has happened there. So those are distinct features of those three other kinds of wound categories, which I'm not going to go in further today. If you have questions about those, I can try to field those in the discussion. So what's happened in terms of definitions? So on this slide, what you see here are, in red, are some things that have been added to broaden the description or the definition of pressure injury. And this was from the National Pressure Ulcer, no longer Pressure Ulcer, Pressure Advisory Panel. I'm having a hard time, changing my words. But what has been added here to the definition is that it now includes things like medical or other kinds of devices. And there's a whole area that's been included down at the bottom that you see there in terms of microclimate and other factors that play a role in the appearance and the etiology of these. So those are things that have broadened the definition here, and I think that's actually quite helpful. So some examples. Now I did tell you that this is a neuropathic ulcer, and that's how this would be classified. It wouldn't be classified as a pressure ulcer, but it does result from pressure. This is over the malleolus on a patient from long-term care, and of course this is a classic example of a pressure ulcer that involves a heel. And we'll talk a little bit more about those characteristics that are seen in the slides as we go along in terms of treatment options. So what's the current thinking about pathways of injury? Well, long ago, some years ago, probably 50 or more years ago, a study was done that documented capillary closing pressure. And what that showed was that the closing pressure of capillaries happened when exposed to a pressure of 12 to 32 millimeters of mercury. Well, that was a fine study. It was done in the finger. And so what has been learned since that time is that that kind of pressure, which was sort of taken as gospel, and the pressure at which we needed to avoid in terms of pressure against patients' skin, it actually varies very widely with a number of things, including the location, the age, and the disease. So it's not quite as simple as if we just keep the pressure less than 32 millimeters of mercury, we're golden. We now understand, have a model that's come forth that really looks at what's happening in terms of more than just pressure. So of course there's always the direct pressure here. This is a bone, but you get other stresses here along the tissue bed. So think of these layers as tissue layers and the compression happening at this point. So let's talk a little bit more. Let me scroll through on my other screen here, if I can do that. Oops. Doesn't want to move. Wake up. Well, I'll keep going over here. So that idea of pressure, there's pressure, and that is coupled with intensity. So early on, we had that 32 millimeter closing pressure. Then some other studies came along that showed something as around 60 minutes could create damage to the tissue, provided the pressure was at a high enough level. So this idea of intensity of pressure, how much is the pressure, and then how long is that pressure actually operating in contact with the tissue makes a big difference in terms of whether somebody develops a pressure ulcer. That gets coupled with this idea of tissue tolerance, which we've been actually talking about for several years, but it involves some kind of newer thinking around not so much skin integrity, but this idea of the microclimate. And I'm gonna talk a little bit more about the microclimate. So when we think about pathways of injury, for sure it's pressure. We know that, but it also includes a couple factors. One factor is friction, another factor is shear. So shear happens in this situation, and it happens in combination with pressure, which is occurring at a sort of perpendicular level to the tissue, and shear happens along the tangential layer here. So that in actual fact, the pressure is coming here, but for instance, if the bone, someone's sacrum, for example, is sliding down here, you're going to get this effect of the tissue kind of pulling against each other and creating this deformity here that you see with these curved lines. So that is actually moving that tissue in a way that creates what we call shear damage, and that's associated with deforming and distorting the tissue, but it's also associated with compressing capillaries and blood vessels in a way that can reduce blood flow. So shear itself is impacted by friction. Friction, happens when you have two surfaces together, and friction can make shear much worse. And the factors that primarily affect friction are moisture and the surface that somebody is on, what layers they have between them, what those layers are like, what the textiles are like, what the support surface is like. So the three of these areas, pressure, friction, shear, and then gravity and friction come together to create a situation where there's a lot of stress and strain on the tissues. Now, the microclimate. Interestingly enough, in 1976, at a conference in the UK, so think about that, that's over 40 years ago, they were talking about the microclimate. So imagine that. And then it sort of like disappeared for the better part of 40 years. And I think what everybody did was sort of jump on the pressure shear bandwagon and there were a lot of developments in terms of surfaces we put people on or positioning and things we did. Now, all the rage right now in the literature in the newer things around pressure ulcers, this is adding in this whole component of microclimate. So it's becoming clearer that there are other things in addition to the three things I've mentioned that impact what's going on to create a problem for patients. So humidity, we think about that as in terms of ambient humidity, but also in terms of humidity right at where the skin and the surface interface. So there's a certain amount of humidity there that's just there. It affects what's going on with the skin. And then there's moisture. That can be there's a couple ways we can think about that. That can be on the skin surface, and that can also be subepidermal. Now, if you get an increase in subepidermal moisture, that is typically an indication of damage. And there are ways that we can measure it, not so much easily clinically, but in research applications. So the skin surface moisture might have to do with perspiration, might have to do with fluids that skin's in contact with, and subepidermal moisture would have more to do with potential damage going on in the tissue. And then there's temperature, which does have an impact. It has an impact on the metabolic activity of tissue, and also interacts with these other factors. So when temperature increases, I think, about 1 degree, the metabolic rate goes up about 10%. So if you think about the skin having a higher temperature, for instance, in someone with a fever, and then also being exposed to pressure, friction, shear, moisture, you've created a whole constellation of factors that then render that skin at the stratum corneum weaker and more susceptible to damage. So the whole thinking now is around these multifactorial causes, and that leads us to think in terms of assessing the patient and treating the patient in looking at multiple ways that we can impact all those factors. So exactly how big is this problem? If you look in the literature, you're going to find an array of prevalence rates, and I have them listed on the slides here. And very high risk in patients that are immobilized in the operating room, in ICU. I'm sure some of you seen heads nod in the room, are well aware of that. Long-term care, there's quite a range, but we know that's a particularly vulnerable population, as well as home care patients. So it does occur. I think I read in one of the papers I looked at that it affects around 3 million people in the United States annually. And the cost is fairly hefty. So a couple examples. This was a patient in long-term care. Actually, I showed you this ulcer earlier. It's now been, in the earlier picture, it was cleaned up. This was a gentleman, he had dementia, Parkinson's, many things going on, many comorbidities, and he had this ulcer, and this is at the 6-week point. He was in a long-term care facility. This gentleman, this is his sacral ulcer, or coccygeal ulcer, he actually had a cardiac bypass, and in the hospital he kept telling people his tailbone hurt. And at that particular time, this is a number of years ago, assessments of the skin were not done the way we do them now. I work at Harborview, and we assess skin every day, and sometimes multiple times a day, and we surely assess people when they come into the institution, because we need to know what their skin condition is so we can take care of them, and we also have liability around hospital-acquired pressure ulcers. So we need to identify these and document them. But in this individual's case, so he complained about his tailbone hurting, and this ulcer was not discovered until he went back for his post-op visit with his surgeon, and the surgeon said, well, let me take a look at it, and lo and behold, he had a stage 4 ulcer on his coccyx, which took about 6 weeks to heal. Now, who is at risk here? That is kind of a major problem, because there are like a multitude of studies that identify many, many, many factors that have been associated with vulnerability and risk. And the question is, how do you sort through them? Some are significant in one study and not another. So a group of investigators, this is an international group of investigators listed here on this publication. It came out in 2013, have come up with a systematic review of many papers that looked at these risk factors. And they were able, through their multivariate analyses, to boil major risk domains down to 3 areas. And those fall out here. And they're actually not too surprising. So mobility and activity as a factor that's assessed in a variety of ways. So it might be a mobility score, it might be an activity score, it might be saying whether the patient is bedbound or not. Studies, that turned out to be an independent risk factor for pressure ulcers. Perfusion, they included diabetes in that, is another area, also not really much of a surprise based on our model of pressure and what that might do to the vessels experiencing the pressure and shear. And then skin pressure and pressure injury status. Skin status. So skin status really has to do with how healthy is somebody's skin. What does it look like? What kind of issues do they have? Is it dry? Is it moist? Pressure injury status has to do with the fact if they've had a previous pressure ulcer, then that is an independent risk factor for subsequent ulcers. Or if they have a current injury, that's a risk factor. So that tells us in kind of general categories who we can look for. And sort of a very simple way to do like a global assessment is if the patient cannot move themselves or tell you that they need to move, then we know right away that person is at risk. So, I mean, take the patient in the operating room. We know that risk assessment scales are notoriously poor at predicting ulcers that are going to occur in patients having surgery because they all are at the highest level of risk, right? Because they cannot move for themselves. They have a number of other things going on. So that's sort of a global measure one can look at to capture mobility and activity. Now you all, I understand, are particularly interested in older adults. I'm interested in them too because I'm becoming one. So, and unfortunately, we all experience this, what happened to our wonderful baby fresh skin as we get older? Well, it does change. It changes with aging. It also changes in response to being exposed to the elements in the environment. We know that. So right now, all of you people that are young, start using sunscreen and protect that skin. But we see a lot of thinning, and we see flattened layers, and a number of changes in the cellular functions of the skin that just render it more susceptible to damage. And the capillaries are fragile too. But if you aren't aware of it, I just want to point out to you that these things that are called Rete ridges up here that I'm tracing are actually what interdigitate to sort of hold the epidermis and the dermal layers together. And those ridges actually flatten as people get older. So Barb mentioned people might be interested in skin tears, and I actually have a little bit about those coming up later. But the skin tears often result in older people because of the loss of these ridges. Not only, it's also the changes in the skin, but it's also the structure of the skin. So, based on what I just told you about those major areas that were identified, mobility, perfusion, and skin status, a new kind of framework has been proposed by that same group that did the other paper, the systematic review. And what you see here are these, on here we see the mechanical issues that we talked about, load and pressure, and we see other things like thermal properties and mechanical aspects of the skin, and just the person's morphology. We have a huge range of sizes in people. And actually, we always used to think about pressure ulcers happening in very thin, frail people. Well, in fact, they happen in all people. And so extremes of either end of the spectrum are risk factors that should alert your attention. But down here are these other things like poor perfusion, diabetes, moisture, low albumin falls out, and then immobility, big factor, which I've mentioned, and decreased sensory perception, clearly, and particularly in certain populations, which you're well aware of. So that's kind of a new framework, was actually somewhat nice. It's a little less complicated. It might have a little more clinical utility. It might cue people to not only think about pressure, but then think about these risk factors, and then how might we modify those. Just highlighting those there. So, common locations. Y'all are aware of these. We've known these for a long time. But it's also good to think about uncommon locations. So, what do we got here? This is the back of this is a calf. This patient is prone, and we clearly have a deep stage injury here, and that was actually related to a medical device. Anybody in the room want to hazard a guess about what happened there? Sorry, I'm sorry. A splint. That's a good guess. And that definitely could have happened. That particular injury was occurred by a Foley leg catheter bag in a 20-year-old individual who, was pretty well nourished and young. So what we would call a medically related pressure injury, medical device. It's always a surprising one. And you can see this is definitely a deep injury because we've got the Achilles tendon exposed. The other thing I didn't mention was that individual was a paraplegic. So had immobility, had sensory perception, and had this pressure component with this medical device. So let me go a little bit into staging and talk to you about the new stuff there. It still is used to describe the extent of injury. It is not used as a way to evaluate healing. There are other instruments to do that. And you can do it. You don't have to remove it says here you follow removal of necrotic tissue. That's if you want to really know the depth of the injury, but that isn't always possible. Once you stage an ulcer injury, it doesn't change. So that there used to be a phenomenon that went on where people would say, well, it started as a stage 4, and now it's a stage 3, and now it's a stage 2, and that has been out of practice for several years now. But in case you see that happening, you can correct that. And it is only used for pressure injuries. So we don't use this staging to look at venous ulcers. We don't use it to stage diabetic ulcers. We use it for pressure ulcers. I just like that schematic because I think it shows you the layers involved in the stages. So a stage 1 pressure injury, here's an example of what it looks like. And the example on the right-hand side of the slide is what it might look like in a darker skinned individual. So you still get this evidence of damage. It's non-blanchable. It is there. You may have a reddened area. It might fade, but at the time that it's red, it usually doesn't blanch. And the definition of this, according to the NPUAP, has not really changed. The skin is intact. It might be warmer. It might feel different underneath it, and the color will vary based on the person's natural skin tone. Now, a stage 2 pressure injury erodes through the top layer of the skin, the epidermis, but it does not go as far down as the subcutaneous layer. And what's different here is that in the new definition that came out in 2016, it's a lot more specific about what you're actually looking for. And in this case, you are looking for exposed dermis, which we saw in the previous slide. It's going to look pink, red, moist. For the most part, you're not going to see fat or deeper tissues. You're not going to see granulation tissue because that implies a deeper level of injury. The definition mentions slough and eschar. It's a little unusual to see that. I'm not sure I entirely agree with that point. These definitions have their own interpretation to a certain extent, but it's not used for skin tears or dermatitis. A stage 3 injury then takes you down below the layer of the dermis, as depicted here in these. And what you see, what's new here is in red, is the call out that you may see fat, you may see granulation tissue visible, also may have slough or eschar, may have undermining, or this term we use for the edges that are kind of rolled in and gnarly looking, that is called epibole. But you have not gotten down like that, the ulcer on the leg from the catheter bag. You are not down to visible fascia yet, or muscle, tendon, or bone. So these are some pictures of deep injury. Clearly this one, there's a cavity there that goes very deeply. You've got a lot of necrotic tissue, you've got some exposed muscle. This is that epibole kind of thing with this very unhealthy looking edge on this wound and some slough in the middle and some also undermining here that's present. So at that point, you're dealing with that kind of presentation. We're talking about a stage 4. And there's the difference, the call out of what you're actually kind of looking for to make that stage. So what's this? Anybody know? I realize it's a buttock. What would you call this? Anybody know, based on the newer staging? This is now referred to as a deep pressure injury. So it used to be suspected. Now in the new classification system, it's just called a deep pressure injury. And in this case, the change here, previously it said that it was intact, skin only, but now it's been broadened, so it's either intact or non-intact. And it's this persistent, non-blanchable area. It has this deep appearance, you know, as you can see here, that kind of purpley. Sometimes there's blisters on it. You really have no idea what the depth of this damage is. And sometimes these deep tissue injuries can heal with the skin never opening. Sometimes they can open and become be able to be classified as a deeper stage injury. So that's one of the newer things. And then there's this whole idea that there are unstageable pressure injuries. And these injuries are, by definition, obscured. So you cannot see. We have this heel ulcer with this classic black, thick eschar on it, and you really don't know what stage that is. You cannot guess. You don't know. Now, according to the NPUAP, there's an assumption that this is a stage 3 or 4 ulcer. But everybody doesn't agree with that. And so, the best thing is to wait and let it unearth. And that's somewhat important when you're in an institution and you have stage 3 and 4 ulcers, which are considered, unavoidable events or things that you are going to get cited for. You don't want to make the assumption that something is a deeper injury than it really is. And one of my doctoral students, Suniva Zaretkovits, actually did her dissertation, and she used retrospective data, and she looked at patients at Harborview who had these injuries that had been staged by wound-certified nurses. So we had a consistent team certifying them. And she looked she followed the record and looked at what happened to those injuries. And many of them did not open to full thickness. So that's a retrospective study. That's some data. It's published. So it's something to think about when in this whole debate around whether unstageables are full thickness or even stage 3. So I mentioned other pressure ulcer injuries. Unfortunately, we do see these sometimes in the medical setting. This is a Foley catheter-related ulcer here. Maybe some of you have seen that. We've also seen oral lesions here, mucosal membrane injury. Now, on medical device-related injuries, we do use the staging system. On mucosal membrane injuries, we do not, because the mucosa tissue is a different construction than when we're talking about the skin with the epidermis and the dermis and the subcutaneous. So we just document those as mucosal membrane injuries. Clearly, you need to get devices out of the way and use things to pad that or protect the skin. Other skin injuries, skin tears. These skin tears on this face were the result of tegaderm. Got to be really careful when you're using adhesives, and particularly as we were talking about the changes in older people's skin. Many times, I've seen these happen many times where we lose skin. Maybe something that you see more often looks something like this with a skin injury. This was a patient transferred into Harborview, had fallen, not sure where, but this is all, that fragile skin that just separates like that. This came in, had steri-strips on it, which are not really recommended because the minute you put on steri-strips, they're fairly adherent, and then you've got to get them off again at some point, maybe, or somebody might, and then you re-injure the skin. So the recommended treatment for these is to cover them with a non-adherent dressing. I believe they use new gauze here, and then just to wrap it and protect it in like a Curlex or some kind of stockinette or something to hold that non-adherent dressing on that skin. The other thing with older adults or anybody that has fragile skin or skin tears is have them wear long sleeves, have them protect their skin that way. The other thing about skin status is moisturizing it. That helps a lot in preventing things like skin tears that result from lack of liquid or fluid in the moisture in the skin. So things to think about when you're taking care of people, and to watch them when you're moving them. I mean, they just bang into a bed rail or something, and they have this skin tear, and they're painful. So the other thing that has kind of gotten confused with pressure ulcers is this condition now referred to as incontinence-associated dermatitis. And it does present sometimes like a pressure ulcer, but the difference really is kind of based on whether or not you have a real pressure suspected cause. So if you don't have any reason to suspect that this pattern here is not really a true pattern, and you see this kind of stuff at the edge of it, this is probably from incontinence. And then it can erode through the dermis, so you can have skin loss. But it's not really considered a pressure ulcer, so you classify it as a dermatitis. Okay, let's move on to more of the meat here, which is around prevention, treatment, and guidelines, though there's lots of them. So they're listed here. You can Google them. Many of them have quick reference guides. The ones I'm most familiar with are from the NPUAP and down below the Wound Healing Society guidelines, which were originally written in '06, and then we updated them in 2015. So, is prevention possible? So the first order of the day is to assess risk. And the guidelines and recommendations are that you use a structured approach using ideally a validated scale. Probably in North America, everybody uses the Braden. The Norton and Waterlow are used in other parts of the world, including Europe. And the predictive validity, as I mentioned earlier, the Braden really is not a great tool to use in operating room patients, surgical patients, or even intensive care patients. So it varies by clinical setting. So they have better predictive validity in long-term care settings, for example. The standard of care is really to do this within 8 hours of admission, regardless of the setting. You want to look at all those three things, those three areas, which are usually documented on these assessment scales. So mobility and activity, skin status, and whether or not they have current or previous ulcers, and anything affecting their perfusion, diabetes, for example. Okay, and those are called out here. Nutrition is also another variable. It didn't fall out as a completely independent risk factor for pressure ulcers, although it's received a lot of study, and things we know about nutrition are that recent weight loss is important, more than 5% in a 30-day period, and greater than 10% over about 180 days confers risk. And what they're intaking, are these people eating? Can they take in nutrition? And albumin is, it has its limitations, but it continues to be cited and used as a broad indicator of risk, as well as pre-albumin as a measure. But clearly, clinically, we get albumin a lot more often than we get some of the other measures. And these are just, screening measures. Of course, if you had a nutritional consult, you'd get all kinds of other data that would help determine what to do about the nutritional status. You see the other things that one can consider when assessing risk listed over here: body temperature, a person's age, their perception
All right, would you mind saying a couple words for me?
Okay, when I was talking about the instruments,
Okay, yeah,
Okay.
we are all good now, thank you.
Okay. What I also wanted to mention about the risk instruments, the three there on the scale, the Braden, the Norton, and the Waterlow, they all have pretty similar sensitivities and specificities in their testing. Okay, so we'll move on here. So prevention and treatment guidelines talk about these things. So based on that model of pathways of injury, we talk about reducing pressure and friction. That includes position changes and also something that's relatively new. We used to say keep the bed, ideally don't have it higher than 30 degrees, but actually the newer guidance is if you can keep it lower than that, if it's safe for the patient, if they don't have aspiration or pneumonia-related concerns, that kind of thing, keeping the bed lower is better because of that shear and friction kind of problem. And I don't know if any of you have ever been patients before, but friction is a real thing because when I had a knee replacement in August and I got stage 2 injuries on my elbows from pushing myself up in the bed. I was only there 2 days, and they were really quite uncomfortable. So actually I'm going to talk about a treatment further on that could be useful in that situation to prevent that happening, because it's a real thing and it's rather uncomfortable. Yeah, I showed it to my orthopedic surgeon and he said, "What's that?" I said, "It's a pressure injury." So these are the things that are covered in many of the guidelines here. There'll be some more that I'm going to go over. But in terms of protein, so this is when people, actually for preventive and for treatment, you want to restore the macronutrients. And the recommended level sort of generally is 1.2 to 1.5 grams of protein per kilogram per day. And in terms of energy, 30 to 35 kilograms per day. Clearly, we want to treat infection. I'll talk more about preparing the wound bed, but what do people think about massage? Is that helpful? No, yes, no, don't, no? That's a big, it's a big no. It's been a big no for a long time, but it seems to keep persisting out there that people want a massage, and it is not supported by any kind of evidence. And in fact, the thinking is that if you massage injured tissue, you're likely to create more damage. So again, and we'll talk a little bit more in detail on these, things that are in all these guidelines that you can delve into in greater depth are listed here in terms of topical treatment. Clearly, because of things like moisture and incontinence-associated dermatitis, we want to manage incontinence and protect the skin. I think I also forgot to mention on the incontinence-associated dermatitis that is indeed exactly what you do. You cleanse the skin very gently, you moisturize the skin, and then you put some kind of really good barrier on it. What might that be? Well, that could be something with zinc, some kind of zinc or a dimethicone or petroleum kind of base, because that will like lock in the moisture and protect it from getting in contact with the skin and more irritation. I'm going to talk a little bit in a few minutes about adjunctive therapies, in case you have questions about those. So that question I had in the beginning, are pressure ulcers, injuries, avoidable? So that's been debated for quite a while, and it's recently there have been some consensus conferences on this, and in 2014 there was one by the NPUAP, big conference. I can't remember where it was held, but we all got together and there was this whole discussion and a Delphi kind of approach to say, are these avoidable or unavoidable? And the conclusion is unavoidable pressure, at that time we called them ulcers, do occur. And then more recently, the Wound Ostomy Continence Nurses Society came out with a position paper on this, saying that, given everything we know about how complex individuals are, that it's reasonable to say that not all pressure injuries are avoidable or preventable. Now, that being said, what's important to say about that is that we still want to try to prevent ulcers. And so they're really unavoidable when there are situations where we cannot intervene, or we can't because of the patient's condition or their safety. And I work inpatient, so intensive care comes to mind, and clearly there are patients that are so unstable for a variety of reasons that we can do very little in the way of moving them. So we have to try, and they're on vasopressors, and they have a number of other things going on. So, but the idea is that you assess and you treat and you take care of the things that you can take care of. And I think where you become at risk for liability is if you haven't done those things. So it's really important to do those very thorough assessments and take whatever preventive actions you can. So that's a thumbs down. Are they always avoidable? Okay, let's take a quick tour here through different kinds of interventions. So support surfaces, I don't know if you find them as confusing as I do, but they are called all kinds of things. There are very many different kinds. What we have called them has changed over the years, and what they're really designed to do is to help with that pressure relief, right? So that's a major area of prevention and treatment that you want to address. And now the whole microclimate conversation has come in. What we do know about these surfaces is that most of the studies have taken a surface and compared it to a standard hospital mattress. So that's what we know it works against, right? So what we do know that is a good thing is that we want high specification foams. So that means that's foam that's denser and doesn't compress, and it's of enough depth that the person doesn't do that thing we call bottoming out in. So that's an important factor that's come out through research on these surfaces. And the other kind of thing is many of these are active overlay or mattresses that go on top. Some are built into beds and otherwise. But what the new way that they're being talked about is in terms of either being reactive surfaces or active surfaces. And to kind of make this as clear as I can, because I had trouble wrapping my head around it, reactive surfaces are ones in which this is what happens to the patient. They can kind of immerse in the surface here, and then this term is called envelopment, okay? So, and then in the end, probably with most people, what we have is a partial immersion with envelopment. And the whole idea here is we're redistributing, we're having more surface contacted by the bed, and that does have an effect on how much pressure is there. So those are the reactive support surfaces, and then there's active support surfaces where the pressure actually alternates and changes. So those fall into the category of devices. Oh, my little thumbs are in the wrong place. Well, they're kind of in the right place. But what's the evidence? So I just mentioned you want higher specification foam. So if you're just putting someone on foam, or if they're in a home situation, someone orders up some foam online, that may not be adequate for them. Medical grade sheepskins have been shown to actually have some preventive benefit. Now, if we get into the merits of higher tech, constant, low pressure, alternating pressure, all that kind of thing, unfortunately, we don't know. And the Cochrane Library has a 2015 review that basically states that most of what we know is that any of these support surfaces are better than a standard hospital mattress. So that doesn't help you very much. But the other flip side to this coin is that not one surface is going to fit everybody anyway. Because you got to look at, do they need a surface that is going to have less friction? Do they need more low air loss? So is it moisture a problem or humidity? The WCN concluded this too, and I found a paper on specifically looking at surfaces for older adults. And I was thinking, okay, maybe there's a recommendation there. But what they came up with is that alternating pressure support surfaces are effective, but again, compared to not high specification, but standard foam mattresses, and we can't say that one is better than another. So there you go. And that continuous low pressure and the sheepskin are better than sort of standard care. So that's sort of the state of the science now in terms of, do something, but you can probably choose between a variety of things based on the patient. Additional preventive measures for pressure are with chair-bound people, doing a complete seating evaluation and getting proper cushioning for them in those chairs, to do pressure releases. They need to learn how to do that about every 15 minutes if they're just, particularly immobile in the chair, if they're not able to shift at all. Heel pressure is really important. I've shown you a number of pictures of nasty looking heels. And what you want to do in these cases is you can lift the heel, you want to lift it off the bed. In this case, the heel is actually suspended in this device, but the device actually goes up the leg, so it spreads that load. So that's important. We don't want to create points of pressure. Relieving between joints, and I mentioned previously the head of bed elevation. So the hallmark of wound care in general, and it also applies to pressure ulcers, is this idea of infection control and wound bed preparation. So what we know is that all of these chronic wounds are colonized. So, we don't typically treat them with sterile technique. We use clean technique. There's many common pathogens, but we also know from some more molecular studies that there are a whole range of organisms in there that we have no idea about. So they're often polymicrobial. And that whole literature is evolving. And you can have either local or systemic infection. A lot of the times it's local. Wounds typically that are have high bacterial burden or are infected, they don't always necessarily respond that well to systemic antibiotics. So that's where we get into wound bed preparation. In terms of the very problematic osteomyelitis, this should be suspected in deep stage 4 ulcers, particularly if you can probe to bone. It has been documented to be in about 30% of non-healing stage ulcers. We particularly suspect them in areas of the ischium, the sacrum, the feet in particular. And the standard of this is to do a bone biopsy to identify the organism and then put people on 6 weeks of IV antibiotics. Now, for wound bed preparation, what are you going to do with this heel? You guys in the room are kind of, on the spot. What are you going to do with that heel? Nothing. You're not going to do anything with that heel because the standard is with ischemia or people with diabetes, that kind of situation. If it's a dry, stable eschar, we leave it alone. We protect it. We get pressure off it. We get them not to keep bumping it, whatever they're doing. But we don't go in there gangbusters and start doing this series of events, which is removing necrotic tissue, flesh, and so forth, which we would do in this kind of an ulcer. That was a trochanter on the bottom. So debridement. Debridement, we learned how important debridement was when the studies for regranics were done. And we found that patients, there was a multi-site study, and the patients that really did the best were patients that were in sites where they got active and aggressive debridement. So this was not on pressure ulcers, this was on diabetic foot ulcers. But it was about that time, and that's been a good, maybe 20 years ago now, where we were like, oh, hey, debridement. I guess that's really important because it makes a difference in how things are able to respond to therapies. So there's different types. If you do selective, that would be with sharp or conservative sharp debridement, which Nobody does unless they are trained to do. If you want really quick removal, you want to really get that wound moving quickly, you want to have surgical debridement. But otherwise, selective sharp debridement, that is something that nurses can be trained in, as well as advanced practice nurses or physician assistants. Then there's a whole range of selective necrotic and viable tissue removal, and the types are listed there. So autolytic occurs, as you see here, under a dressing that keeps this wound moist, and the body begins to autolyze through its enzymatic activity and start clearing off that slough that you see. So that's autolytic. It's slow, and if you don't see improvement in a couple weeks with autolytic debridement, you want to think about using a different method. Another method that is can be effective but is kind of slow has to do with enzymes. And so here on this particular area, this would have to be cross-hatched, and there's certain things that inactivate these enzymes. There's only one on the market now that I'm aware of. I believe it's collagenase or Santil. But they do work. They work, and they work over time. And they require application and then an effective dressing cover, but they will help clean the wound up. Dakin's solution is pretty controversial, but it does have somebody's cringing here in the room. But it can be used in certain selective conditions. You don't want to use it for long, and it is antimicrobial, but it's also cytotoxic to all the good cells that we want to come into these wounds to heal them. And you need to protect peri-wound skin. Now, larval therapy is also considered selective. Yeah. So I don't know if anybody, you can self-identify in the discussion if you've used larval therapy. I have not ever used it, but it's actually pretty cool. And people get a little creeped out about it. But, it all comes, they're medical maggots, they're trained for this, and they come in a sterile container, and I think leeches are kind of a little creepier to me than the maggots. But in actual fact, I attended once a training for this, and they come in a kit, and they have this nice border so that they're contained, and then you get them in there using this little instrument, and there's a top cover that goes on, and there they are. Everybody's friend. And then you cover them again, and they do their job, and they're actually, so this was, I'm not doing the arrow right, sorry. So this was at the initial application in this example, and you can see in just 2 days, that's pretty remarkable cleanup. And in order to jumpstart any wound, you've got to get it, you just have to get it cleaned up, and it's sort of a question of what are the patient's goals, what are your goals, how fast do you need to accomplish this? So it's something you could keep in mind. So biofilms, all the rage of late in wounds, have been for several years now. And, they occur everywhere. They occur on our teeth. They occur in pipes. They're ubiquitous. And we know we have evidence that they occur in wounds, including pressure ulcers. And they form these very crafty colonies that they encase themselves in this matrix so that you can't get to them topically or systemically very well. So contrary to popular belief, there's really no good evidence that you can see a biofilm. When people see a lot of kind of slimy slough or whatever in an ulcer, they think, oh, it's got a biofilm. Well, we can't really see them, but we do know they delay healing. And you can suspect them if you've got an injury or wound that is not healing very quickly. So there's something to expect or think about. The other thing is if the wound is not responding to antimicrobials. The thing about biofilms is as soon as you remove them, you have to immediately get some treatment on them. And right now, trends are leaning towards silver-containing products. Cadexamar iodine is maybe edging a little bit ahead of the silver-containing products. So you want to get that on there right away because the biofilms reform in about 3 days. They start within 24 hours and then they proliferate and they start forming that matrix again. So you're going to need probably repeated debridements until you can get that wound to a healthy enough state that and the bacteria are controlled. The issue I should mention around silver products is the worry about developing resistance to those. So we try not to use those for extended periods of time. The principles of topical care mentioned here on this slide are standard for really all wounds, not just pressure injuries. You can read those. There are, as you know, many, many choices. And so the best way to think about choosing a product to treat an ulcer with is to ask yourself, what do you want to do? Do you want to protect it? Do you want to moisturize it? Do you want to control exudate? Are you interested in treating bioburden? Honey, by the way, we use a lot of that at Harborview, is quite effective. Odor, you can use different kinds of products for that. So instead of focusing on a specific product, because there's so many of them, if you just go more into a category of what you want to accomplish with the wound, then that's a reasonable way and a recommended way to proceed. So I'm not going to, you can read these, it sort of tells like when you might use them, and they're basic categories and you can read about them. But what I did want to share with you is kind of what's new in the way of dressings. And what's new is this idea that we can use dressings to prevent these pressure injuries in some cases. And so there are these dressings out there that are this multi-layer soft silicone. They come in different sizes, some for heels, some for sacral areas, and they have these multiple layers that include breathability, and they also have the friction layer here. We were talking about friction is really reduced. These slide very well on top of surfaces like sheets or things that one might be sitting on. And I think they'd be great for elbows too, for people that are scooting up in bed and get sore elbows. At least they would be worth trying. So there have been some studies in ICU patients and also in the labs that indicate there's some level, you wouldn't think this is true, but there's some level in pressure reduction. But I think it's the primary effect is probably around shear and friction reduction. And so many institutions, I've heard of some, that are actually using these as a preventive measure. So that's been fairly new. Now what about adjunctive therapies? Right now, we have one growth factor on the market, and that is platelet-derived growth factor. And to be honest, it's only really approved for use in diabetic foot ulcers, neuropathic ulcers, but the recommendations, these guideline and evidence-based recommendations do say consider this for use in a stage 3 or 4 if it's unresponsive to comprehensive therapy. So you really have to cover all your bases with really good standard comprehensive care. But if that just isn't working, this is something that the guidelines give some support to using. Again, you absolutely have to have a clean wound bed or a debrided wound bed, or you're just wasting your money on this. It's like sprinkling seeds on ground that's absolutely dry and unable to support anything. Negative pressure wound therapy, definitely also one of those things to consider if you get an ulcer that hasn't responded. There's pretty good evidence around this and what its effects are. It does definitely reduce edema, it increases perfusion, and it does stimulate granulation tissue. Those were early studies done when negative pressure wound therapy came out. So it does, pretty much suck things right out of the wound. It drains the swamp, so to speak, of the wound. So That's something else to consider. We use a lot of them in a whole variety of wounds at Harborview, and there's home versions of this in various iterations. So also something that can be considered. Negative or electrical stim, this has been around for quite a while. There's some pretty good evidence that both direct current and high voltage pulsed current do help ulcers heal. It's not for everyone, but again, it's one of those things the guidelines recommend you can consider for stages 2 through 4 that have not responded to our more conventional therapy kinds of measures. So there's still a lot of questions about it in terms of where exactly. Some studies place the electrodes, one on the wound, one on the skin, one either side of it, different places, different lengths of time. So, obviously, if you use this, you want to consult probably with I would suggest physical therapy, because they seem to be the profession that is most informed about electrical stim. But it's definitely one of those things that can be considered. And hyperbaric oxygen just does not have enough data right now to even recommend for use in pressure injury, although it does have good evidence for other types of ulcers like diabetic foot ulcers, but not enough for current recommendation. So, wrapping up here, time frame for healing is we want to assess these ulcers at least weekly. What are you going to do with this ulcer? You're going to debride it. Yeah, you could sharp debride it. You could, depending on what the patient's situation was, you could use a slower technique. But we got to get all this. We got to get this off of here. The edges don't look very healthy either. Sometimes when ulcers have been around a really long time, if you have access to surgical consult, they can take them and clean. Just take those edges right down so they get to a stage where you're really starting with a fresh wound. From the get-go. Pressure ulcers are slow to heal, so stage 2 heal in about 8 weeks, but only 17% of those that are stage 3 or 4. You want to look, pretty much with any wound, you want to look for some evidence of healing within 2 weeks, and if you don't have that, then go back and look at other factors. Reevaluate what you're doing, reevaluate the patient, and look for other reasons that it's not healing. Like, is it the positioning? Are they not staying off it? What is it that we just have not? And if, in fact, you are doing everything and you've really covered the bases, then you could consider one of those other lines of therapy. And if you can get healing within that early time period, like within 2 weeks, that does predict closure for these. Referrals, I think it's really important to think about referring when you're sort of out of your depth. You would need to get some expertise in there. Patients that have complicated situations, maybe they have mixed disease, venous and arterial. There are wound clinics around in many areas. I know not available to everybody, but consult specialists, vascular surgeons, podiatrists. We do all kinds of studies as necessary, and the wound clinics or wound teams can direct you in what kinds of things need to be added to evaluate the patients. So it's really, it's kind of a team sport. And wounds don't really belong to anybody because they occur in patients with any kind of diagnosis. So it's not like we necessarily have wound, a physician or a nurse that are specifically wound focused. I like to mention when I'm doing talks that talk about older adults to be aware when someone comes in, an older patient, and you're seeing things that aren't adding up
Okay, we should be back.
Okay, let us know if we're not back on. So red flags are people coming in and the description of the ulcer is not really clear or consistent. Or there's odd locations. Those do happen. I showed you one on the leg, but you want to explore that a little bit more. Why is it in that location? What does that mean? Something else? Does it look like they have sort of disordered care or a lack of ongoing evaluation, or that the care hasn't really responded to needs or changes, and that they're not really applying evidence-based or guideline-based care? I did some work with the coroner's office several years ago, and some of the cases were really quite appalling, where a caregiver would say, well, they came in with this just several huge, really advanced stage injuries, and the caregiver would say, well, it wasn't there 2 days ago. I mean, it's really hard to believe, but in fact, that kind of thing does happen. So I think particularly with people that are older and vulnerable, being alert to that is important, and looking for things that might signal. It's not always as blatant as that. Sometimes it's more subtle. And sometimes it's just they don't know what to do. They don't know how to care for it. So it's not that they've done anything wrong. They just need more education. Okay, I think we should stop there, 5:15, and go to the chat box. Is that right, Barb?
Okay.
Is there any evidence of turning patients every 2 hours for pressure injury prevention?
Oh, great. I'm glad you asked that, because I meant to mention that. Not really. That just became the standard, and I think it fell out of some of those early pressure studies. But it is our standard, and it's not really a bad place to start. But depending on what kind of surface the patient or the person is on, there have been some studies with people cared for on high specification foam. I think it's called viscoelastic foam. That were turned every 4 hours. This was a study in Belgium, I believe, a couple studies done in Belgium. And they actually, the patients did fine with a 4-hour turn schedule. So I think there's a lot of work to be done on this. I think just like we don't have any one risk factor, I think we don't have any one magic formula. And a lot of it depends, on the patient. And so if you're seeing reddened skin on areas at 2 hours, then maybe it needs to be less than 2 hours. If you're not, and they're on a great surface, then maybe you could turn them. Although I think regulatory-wise, if you're going to be judged on documenting, then you clearly have to document with what the standard is. But scientifically, we need more evidence around that.
How would one secure a dressing on the face without an adhesive?
Well, that's a good. You could choose something that's a little more forgiving, like some foam type dressings. Like if you had something you were securing, you could put the dressing on and then put a foam border dressing on top of that to secure it. They have a little less caustic adhesive to it. Or what we often do if we need to use an adhesive, we will take Kerlix or gauze, and you tape over that until you can get to some kind of area, or actually, go all the way around, although you have to be careful with that because you don't want to create some kind of tourniquet effect. Yeah, on the face, I think I agree, it would be difficult. Burn netting? Okay, great. That's a great suggestion from here on site, as they use burn netting. On the face, like just over the head? Where do you work?
I used to work at Harborview.
And I was going to say at Harborview, I mean, Regional Burn Center. Yeah, netting works a lot. We use it for underwear to hold dressings in place on the trunk or across. So we use a lot of netting.
Can you speak a little bit more about the use of honey?
Well, honey, it comes in different forms. There's sort of it's impregnated in dressings, and I personally haven't worked with it, but I know that the wound care team at Harborview does use it on a lot of ulcers, and they use it on ulcers where they think bioburden is high. So they feel that it does have antibacterial properties, and it's a certain type of honey that's in this product. It's made from a honey in New Zealand called Manuka honey, and it's processed and it's made into these dressings. There are some very good papers on honey and systematic reviews of the effects of honey and various things, but I think it's getting a pretty good track record. Sorry, I don't know a lot more about it.
And what about the use of peroxide?
Yeah, no, it's not really recommended. To begin with, it's really a feeble way to try to control bacteria. It has sort of a quick burst, and I think it makes clinicians feel good because we see it bubbling up, and we think, but it actually can damage cells that you don't want. So it's really better if you're going to, and I think people were kind of using it for cleansing, and we really try to cleanse now with physiologic solutions so that we're not using things that are really caustic or damaging to cells. And we try to get the stuff out of them other ways, like through those different techniques that I was mentioning around debriding.
So you've already answered most of this person's questions, but so far as enzymatic debridement is concerned, have they come out with anything comparable with, and I'm going to pronounce this wrong, ELASE? ELASE?
ELASE.
E-L-A-S-E?
Yeah, ELASE. So I think, I'm not sure, but I don't think ELASE is on the market currently. And so what we have, and I can't remember what the enzyme was in ELASE, maybe this person knows. So what is in the current on the market product is collagenase. So the ACEs, the enzymes do work a little bit differently on the type of tissue. But to be honest, we do a lot more conservative sharp or aggressive sharp debridement than we do, I think, using enzymatic. That's just where we are. Might be different in your settings.
What do you recommend for patients who sit for long periods of times? What do you know about Rojo cushions?
Okay, I also forgot to mention, so in systematic reviews that have looked at seating surfaces for patients, it's a little bit similar to the bed mattresses in that, yes, they need some kind of seating cushion. No, we don't know if one cushion is really better than another. Now, I imagine people that work with this population a lot there may be expert opinion in there in terms of what they think works best. I know Rojo cushions have been used a lot, and the ones that I'm familiar with, the Rojo cushion had like these little pockets all over them, and you could inflate them or deflate them to different levels, and you could also like tie down certain pockets to if you had an area under the person's sitting surface where you wanted to relieve the pressure, you could drop a number of these cells down. I'm not sure what the current version of Rojo is, but I think they have a good reputation. But the bottom line is they need a seating evaluation. If they're going to be wheelchair bound or in it a lot, kind of like pretty much all day, and getting around, they need a seating evaluation, and there's a number of seating surfaces that I think are options for people.
Do we have any questions in the room?
Okay.
Okay, thank you
All
very
right,
much.
thank you for your attention.